Hello, this is Dr. James Hall. I am a nephrologist, and we're talking about how to effectively screen patients for chronic kidney disease. This is one of the questions that I get asked a lot from the primary providers, physician extenders, physician assistants, and nurse practitioners. How do we screen patients for kidney disease? And, who's at risk? Well, the biggest thing is knowing some of your risk factors. If you're diabetic, you're at risk because that's the number one cause of kidney disease. If you have high blood pressure, you're at risk because that's the second most common cause of kidney disease. What's the third most common cause of kidney disease? HIV in patients in blacks age 18 to 64, and glomerulonephritis in that other part of the population. Before HIV hit the scene, glomerulonephritis, lupus nephritis was kind of like your third most common cause of kidney disease, but now HIV is third in select populations. So those are the main three categories or four categories: diabetes, hypertension, blacks in the age 8 to 64 who have HIV, and people who have lupus could have glomerulonephritis. Those patients deserve screening for kidney disease because they're already at risk. Now, if you see a patient who's taking NSAIDs and they're over 55 or over 60, that person is probably at risk because they're taking a medication that's nephrotoxic. If your patient is getting an aminoglycoside, gentamicin, amikacin, tobramycin, that patient is at risk for kidney disease or acute kidney injury because they're taking a medicine that's nephrotoxic. So you want to look at your patients individually and not kind of cookie cutter, put everybody in one box. And you want to always check serum creatinine. That can quickly tell you if the patient has kidney disease or not. But you also want to check urine protein levels. Urinalysis tells you qualitative: yes, there's protein; no, there's no protein; yes, there's blood; no, there's no blood. But the urine protein to creatinine ratio tells you how much protein in grams. Now that's valuable because if you got 500 milligrams, that's not a lot of protein spillage in the urine. But if you got 5,000 milligrams of protein spillage in the urine, that's significant. That needs to be addressed like right now. So being able to quickly screen your patients and get to a diagnosis is probably a very good skill to have in primary care. I know a lot of our training is not the best with regards to nephrology for the primary care providers. I'm a board certified nephrologist. I've been practicing 20 years. I kind of know what I'm doing. So I feel confident managing any and all nephrology CKD transplant patients. But primary care providers don't get the training that we get. So I want to try to teach you how to be like a nephrologist and do what we do, and almost it's as if I'm making a decision in your clinic. I want to teach you so you will know exactly what to do. We've created a course, and there's a free webinar you can check out that will talk about all this stuff. And there's a lot of case reports that I want you to look at that will help you solidify your knowledge base. That's the most important thing. You guys are smart. You guys are knowledgeable. You guys have access to all this, online education and information. But bridging the gap between medical knowledge and clinical knowledge is where the challenge lies. And that's what I want to do with my program, is teach you how to do what we do. So all my videos are mainly about that. I hope you check out all my YouTube videos because we're talking about all the stuff related to kidney disease and all the questions I get about what to do with patients who have kidney trouble. Now, so you always want to try to see if the patient has a family history. If the patient has a family history, they're obviously at risk for kidney disease. You want to see if the patient had acute kidney injury or preeclampsia during pregnancy, if it's a woman. If the patient has dysmetabolic syndrome or syndrome X. If the patient has had a past history of some kidney damage or past history of requiring dialysis, or now we're screening people for ApoL1 mediated kidney disease. We're screening people for genetic variants, which has really changed the game. I love it because we can take away a lot of guesswork and dial down to an exact genetic diagnosis of what's happening in our patients. Polycystic kidney disease, that's another well-known cause of kidney disease in our patients, in blacks and whites. People who people who smoke are at risk. Smoking damages those little small arteries within your kidneys. And if you're a smoker, they don't even let smokers get a renal transplant at all. They don't even want them to come in the door. Don't show up. Don't even make a referral because they smoke. And if I had a dialysis patient who was a smoker compared to a dialysis patient who was not a smoker, let's take the non-smoker, because more than likely we'll get 5 to 7 more years out of this kidney in the non-smoker. And I'm all for that because kidneys are hard to come by. I know there's a black market and we got people stealing kidneys, but I'm not stealing kidneys. So somebody got to die for you to get a kidney, or somebody got to donate a kidney to you if you need a kidney. So they're hard to come by. That's why we guard them with our life. We don't want to put it in a smoker or a drug addict or something like that. So, people who smoke are at risk. Smoking accelerates hypertension. It also accelerates kidney damage. So I advise all my patients to stop smoking if they're smokers. What about marijuana? What about legal marijuana? Listen, one cigarette is too many of anything. LSD, crack, Nick Marlboro, Newports, Camels with no filters, marijuana legal or not, homegrown in the backyard, PCP. Our bodies just cannot adjust to all these foreign substances in it. So over time, there's a lot of damage that takes place. It may not be overnight, it may not be a week or two or a year or two, but in time, it will catch up with you. So that's why we advise people not to smoke. If you got smoking-related atherosclerosis in your heart, coronary atherosclerosis, guess what? The same thing is happening in your kidneys. It kind of goes without saying, but most people don't think of it that way. But you can develop renal artery stenosis, which is a stenosed kidney artery going to your kidney, renal artery, from smoking. So that's another risk factor. What else? Being very obese is a risk factor for CKD. In my practice, when I was doing my nephrology fellowship, I never saw obesity-related FSGS. Now, FSGS is a lesion on the kidney. It's not necessarily a specific diagnosis per se, because a lot of things can cause it. It's a scar. It's evidence of scarring in the tissue from something. Gold chemotherapy can cause it. HIV can cause it. Pomegranate can cause FSGS. Genetically, ApoL1 mediated kidney disease. There are a lot of things that can cause FSGS, but that obesity-related FSGS is what we've been seeing lately over the last 3, 4, 5 years, and the patient had no medical problem. The patient come into my clinic. This was like a 35-year-old black guy, came in with a creatinine of 4, 4.5. GFR was around 18. No past medical history, no hypertension, relatively healthy except for sleep apnea, and he weighed about 400 pounds. He had probably 2+ to 3+ proteinuria in his urine protein to creatinine ratio. So we decided to do a kidney biopsy. This guy had obesity-related FSGS. He had lesions, FSGS, focal segmental glomerulosclerosis on his kidneys, because of he was just too fat. Not PHAT, not pretty hot and tempting. Fat, FAT. So he said, what I need to do? I said, you need to lose weight. I can't give you nothing to reverse that. You need to lose some weight. I know we got all these weight loss pills and all this kind of stuff, but naturally is what we tried to get him to do. We tried to get him to lose weight naturally, and he did. His kidney function has stabilized. It has not gotten worse. He is not on dialysis, and I'm hoping that we can keep him out of the danger zone. His renal function has gone up. It's in the 20s now. So hopefully we can prevent him from ever having to require dialysis if he'll keep his weight under control. So that's another person that you should screen for. You should always look for little subtleties or abnormalities in the blood work or the labs that make you think this patient has kidney disease. I'll tell you another one that you look at in the labs. If you see a patient with a low albumin on their chemistry, or the liver panel, low albumin, yeah, I know it could be malnutrition, but how many people you know have starved to death? How many people you know don't have enough food at night? I don't know many, hardly at all. I know one guy, he's a meth head who we've been trying to help, but he chooses to not eat. He chooses to buy meth, crystal meth, instead of buying, a hamburger. But if you see a low albumin, you need to think proteinuria. This patient is losing albumin in their urine, so their serum albumin is low. Your job as a provider is to figure out why. What in the world is going on with this patient that's making them lose protein? Because proteinuria is the first sign of kidney disease that we see in patients with some type of glomerular injury. That's why we check a urinalysis. Proteinuria is the first sign of kidney disease. So these are some of the screening things on kidney disease. I hope it was helpful. Check out our next video, and we will see you then. Check out the webinar below. Thank you for tuning. Bye.